Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto here with my great friend and America's primary care physician, probably even the primary care physician, and he knows a lot about this topic too, Dr. Paul Nelson Williams. Hi, Paul.
Matt just tried to get me to crawl into a hole with shame and embarrassment. But hi, Matt. How are you?
I'm great, Paul. We had an awesome episode. I was not part of it, but was with Dr. Stephen Holt, and you were joined by our addiction medicine crew and this is like a sort of a higher level medication focus for alcohol use disorder, mainly in the outpatient setting. And Paul, I think it's important to start off by saying when we were coming up, Paul, as young people in this field, abstinence was pretty much like if you weren't abstinent, you were a failure, essentially. If you were someone with alcohol use disorder, and we were probably calling it alcoholism at the time. But now we've sort of taken a more, I think, realistic and more patient-centered approach and evidence-based approach that abstinence is not realistic for everybody, and just a reduction in alcohol use actually can improve outcomes, including mortality. So you really have to meet the patient where they are. Yes, for many patients, maybe it would be better for their overall health if they were completely abstinent, but it's just not, it may not be in the cards for them. And a reduction in use is also worth shooting for. Anything to say about that, Paul?
No, I mean all true. I think keeping things patient centered with stuff like this is always really important, and then also recognizing that even if the patient's goal is abstinence, it's really hard. Like these medications are effective, but they're not. They are far from perfect. They are far from slam dunks, and so just accepting that there may be sort of returns to use, and you may not be able to achieve complete abstinence, and being okay with that and supportive throughout the process, and not just viewing it as a treatment failure is really critical, regardless of what the patient's goals are.
So we have 3 FDA-approved medications. We have naltrexone, oral or intramuscular. We have disulfiram, and we have acamprosate. So, Paul, what is this? I was not familiar with targeted therapy. I thought you had to take these meds every day or once a month if it's the IM naltrexone. Teach me something, Paul.
Yeah, I don't know that I can, Matt, but yeah, there's, with alcohol use disorder, there are often triggers, and sometimes patients, and often patients can even anticipate what these triggers might be. So I think on the episode we talked about a Thanksgiving dinner where we know an uncle's going to get us angry, or the anniversary of a loved one's death, or being in a social situation. Like there are times when someone may just know that they're going to be more likely to drink alcohol. So rather than being on a chronic medication, if they're otherwise in a reasonably stable place, they might take medications in advance of whatever this occasion might be to help reduce their potential for use. And that can be done with naltrexone. It sounds like the data is especially good for nalmefene, which is not approved in the US. It's a European medication that has good evidence, but you can do it with naltrexone, that's so-called Sinclair technique. And Dr. Holt even, and I think even Dr. Chan mentioned sort of doing this with disulfiram as
Yes.
well, which we'll talk more about. But you can, that way, what the outcome will be, and also to be less likely to be tempted. Though I don't like framing it in that way, but you can just take it sort of as needed in anticipation. Maybe a day or two before whatever the trigger might be, and that way you're just less likely to drink alcohol during that time.
Right.
That way you're not on a chronic medication with all the burdens and hassles that come along with that. So it's a neat technique that is not used probably as commonly as it could be, at least in my experience.
It sounded like he was advocating like you start it sort of a couple days before and continue it a little while afterwards until you feel like things are settled again. Is
Yeah.
that was my read from the episode. But Paul, when you were talking about this stressful event and Thanksgiving dinner, I don't remember if it's a Thanksgiving dinner or Christmas dinner, but if you haven't watched the TV show The Bear yet, I don't think, but you would love it for many reasons. But there's a Thanksgiving episode where Jamie Lee Curtis plays the mother and she's cooking in the kitchen, and it's like one of the most tense things I've ever seen in my life. Just like she's just like raging at everybody. People are afraid to go in the kitchen. Yeah. The disulfiram, he loves disulfiram. I was shocked, Paul. I did not know this about him, and I obviously Carolyn and Sean did because they work with him or have worked with him. But my gosh, I thought this medicine. I thought no one was using it anymore. Have you prescribed it, and did you know that it was still kind of in vogue?
I don't know that it is. It's got a bad rep. The point that Dr. Holt made, I have prescribed it. It's not my first line necessarily. No, Dr. Holt has a lot of enthusiasm for it. He makes the point, if you don't mind me talking about this for a second, Matt, that the studies that looked at initially were, if you talk about these randomized blinded double blinded control trials, like if you think that what you're taking, placebo or not, might make you deathly ill when you drink alcohol, you're kind of defeating the purpose of studying this medication. Part of the
Yeah.
issue is that you know what you've taken. So if you actually sort of tease out the open label trials where patients knew what study they were randomized into, there's actually really good evidence for the efficacy in an observed setting. So if the patient is watched by a partner, or not even necessarily like a romantic partner, but just someone who can sort of keep them slightly accountable and make sure they're taking the medication. It seems like there's pretty good evidence for this. And he's had a lot of personal success with it. And so is a big advocate for it. So it certainly did make me more inclined to prescribe it than I had been previous to the episode, but it's probably still not the one I reached for initially.
Yeah. Yeah, I thought that was a really smart point about like, usually randomized blinded trials are like are gold standard, but in this case, the placebo becomes very strong if the patient's like not sure if they're taking the placebo or not, and that they might get horribly ill if they try, if they drink.
Right.
So, yeah, I mean, disulfiram, so it comes in 250 milligrams. That's the standard dose. Dr. Holt said sometimes if patients, like, for whatever reason, are able to drink on it and they don't get sick, then he would up the dose to 500 milligrams. But he said it's not common, but there's like some patients just for whatever reason, the way they metabolize it, they just don't have the response. They must be somehow other way metabolizing alcohol. But most patients need to be really careful. Like you need to tell them no alcohol containing products like mouthwash, and even I think he even mentioned like some of the vanilla extract that's like kind of the artificial vanilla can have it, and all sorts of aftershave things like that. So patients just need to be careful. The contraindications, like if someone's cognitively impaired and they don't remember if they took it or not,
Yeah.
that's definitely a thing. If someone has severe cardiovascular disease and then they take this and they get the reaction, it could maybe cause cardiac decompensation. So they don't recommend it. And then he avoids it in really advanced liver disease like cirrhosis with child's B or C, um, class. He does say that if it's like mild child's Pew class A, he would still use it in patients and just kind of follow the liver closely. But I looked this up on Liver Talks, Paul, and I guess there is some concern about like an acute medication-induced hepatitis that could be really serious. So that's why if a patient already has like a baseline sick liver, you probably would not want to give this medication.
Yeah. Above and beyond, and we talk about this in the episode, the fact that I feel like this medication feels sometimes a little bit moralistic or kind of punitive for people who are drinking. Like it's just sort of a built-in punishment, which we talk about. Yeah, that has been my larger concern with
Yeah,
prescribing disulfiram, is the potential for the hepatotoxicity, which
right.
maybe has
But
maybe have been overstated in my brain.
yeah, but I mean, I would at least have a conversation if it was a patient without a contraindication. I would at least have a conversation, and for the right person, it might just be like they're just like because it takes drinking off the table, even if they're having cravings. Like they know they'll get violently ill, and they don't want to end up in an ER for IV fluids because they're vomiting. So I think it works, but like you said, it's a little bit of a tricky conversation. But this kind of reopened the door for that for me as an agent to prescribe, which I just had never really considered it.
And it goes back to your original point of shared decision making and just making sure that we're making informed decisions together, meeting the treatments what their goals are. So if they after this conversation is something you're interested in, I would not try and talk them out of it. And in fact,
Yeah.
yeah, it's like I said, I'm more inclined to reach for it now after having talked to Dr. Holt.
So Paul, just to close it out here, what off-label medications might listeners consider?
There's a bazillion, and there have been lots and lots of like small studies of looking at sort of other things and medications in combination. The one that Dr. Holt would reach for preferentially if the FDA-approved medications, so your Naltrexone, Acamprosate, or Disulfiram, are not efficacious or not able to be used, would be Topiramate, which is even highlighted in the VA guidelines. You have to. It's tricky because it's a medication that has to be titrated slowly, and so you're talking about like increments of 25 milligrams, and so you have to have someone who's able to follow directions and committed to taking a medication and making changes and is fairly well organized, which is not always the case when someone has underlying alcohol use disorder. There's also a lot of intolerable side effects for a lot of folks, so it can make you feel somnolent. Paresthesias are certainly a worry as well, so you just have to be a little bit cautious with those. But topiramate does have evidence to support its use. We talk a good bit about gabapentin as well, Matt. So something that we've all prescribed for a million different reasons, but Dr. Holt is a fan of it specifically for alcohol withdrawal, but also there is some evidence for alcohol use disorder as well, and it does seem helpful, especially in combination with say like naltrexone. So I'm more inclined to reach for that. And we touched briefly on baclofen, which I've known people that have been enthusiastic about. There is evidence to support its use, but it's not one that we talk too much about the episode. But know that there are people that use it, and there is data to support it somewhat.
Yeah. And we talked a little bit about combination therapy. It not doesn't really there's not really strong evidence for it. Sometimes I know you mentioned you might use naltrexone and gabapentin together, but the evidence overall for like something like naltrexone and acamprosate really wasn't didn't seem to pan out.
It's not well supported. That's right.
Yeah. So, I mean, this is a great episode. I really recommend people take a listen. So you can click on the link in the description below. And with that, until next time, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yeah, yummy. And as always, Dr. Paul Nelson Williams, thank you and goodbye.